Thank you guys so much for joining us today. We are excited to welcome Peter Treitler. He is an assistant professor at Boston University School of Social Work. His research aims to improve well-being for people with substance use disorders and inform more effective solutions to the nation's critical substance use challenges. His work examines the implementation and outcomes of health services for people with substance use disorders and how federal, state, and payer policies shape their treatment and recovery experiences. So thank you, and join us in welcoming him. And also let me mention that we will take clarifying questions throughout, but please hold on to substantive questions until the Q&A session at the end. Thanks so much.
Hello, everyone. Thank you so much for the introduction. Thank you to Shelby and Keith and everyone else for putting this together. I'm really excited to be here and to present for Chaz because I follow a lot of the work happening here. It's very relevant to the stuff that I care about and I'm most interested in. But what I'm going to talk about today is healthcare services for people who are incarcerated and at the time of release. So the title of my talk is Improving Post-Incarceration Healthcare Access for People with Substance Use Disorders. And so I'm going to spend a little bit of time just talking more generally about some of the challenges related to health and healthcare for people who are incarcerated and those being released. And then in the second half of the talk, I'm going to present some of my research on a couple of interventions that are being used or are being used more often throughout the country that are supposed to help people engage in healthcare after release. So just to frame everything, and this is probably very familiar to this audience, but we have a huge problem with over-incarceration in this country. And so in 2022, we had about 2 million people incarcerated in jails and prisons in the US. But even a much more staggering number is that you have about 7.3 million people cycling in and out of jails in a given year. So this data is from 2022. And that's really important for healthcare because any jail stay, whether it's only a few days or weeks or months, is very disruptive to people who have chronic diseases or substance use or mental health issues, which are typically disrupted when they go to jail and not well coordinated at the time of release, so they don't get the services they need. And then compounding that is the very large disparities in who gets incarcerated and the racial disparities in particular. So, and then that intersects with healthcare. So, because Black people are over-incarcerated compared to white people, that just exacerbates the health disparities that we see in those groups as well. And so, nationally, on average, Black Americans are incarcerated at 5 times the rates of whites, but there's also a huge difference across states. So, I'm from New Jersey. At Boston University, but a lot of my work is based out of New Jersey, and actually it's distinctive in being one of the states with the highest disparity. So it's about 11-to-1 in New Jersey, which really speaks to the importance of addressing these issues. And then among people who are incarcerated, chronic conditions are very common, and that's especially true for substance use disorders and mental health conditions. So this 49%, about 49% of people in state prisons meet criteria for a substance use disorder diagnosis, and that's a conservative estimate. I've seen much higher ones. I've seen them closer to 65%. And a large number of people who are incarcerated, also around 60 to 70%, used substances in the 30 days before they became detained. And then another about 43% have a mental health disorder. And then you also have just high rates of regular medical comorbidities like hypertension and infectious diseases. And I do also want to add that these are becoming more common because the population in prison is aging because of the sentencing laws. A lot of people are serving out 20, 30, 40-year sentences or life sentences, and so they're aging in prison. And of course, then their diseases become more prevalent over time. And then thinking about treatment, whether people are getting the care that they need in prison, there's plenty of evidence that that's not always happening. So. On the left here, you have people who have reported past 30-day serious psychological distress, so active symptoms of a mental health problem that's causing serious issues for them. Only about 60% had received any kind of mental health treatment since they became incarcerated, and 40% were actively receiving treatment. And then that's even those rates are even lower for people with substance use disorders. And I do want to say this is from 2016. This is the last time state prisoners were surveyed. But it hasn't, from what I've seen, it hasn't gotten too much better. And only about 33% of people with substance use disorder have received any treatment since admission. And then for other chronic diseases, so the evidence is somewhat mixed because in some cases, people actually get better care while incarcerated than they might have in the street. So let's say someone has diabetes and a major part of their treatment is medication and diet. And in some cases, people have an easier time adhering to their medication while incarcerated. And then, of course, the diet is pretty fixed for the most part. And so they may be eating healthier. So there are definitely certain diseases where people can be healthier while in prison. But then there's a lot of other diseases where that's not true. So anything that would require some like real specialty care like cancer or a rare disease, typically people have to leave the prison to get that care. And anyone who's worked in that system knows that that's not easy. You have to essentially send corrections officers with people anytime you send to the hospital. And so the result of that is that people often have long delays in getting care for certain conditions. And then I do want to point out there's also been some recent evidence that people, even for common diseases, are undertreated when they're in correctional facilities. So if you take something like hypertension, what this study did is they looked at the prevalence of these different diseases among the incarcerated population and what percentage of medications for those diseases were sent to correctional facilities. So in the example of hypertension, they estimated that about 0.42% of the US population who has hypertension is in a correctional facility or recently incarcerated, yet only 0.18% of the drugs for hypertension were given out in a prison. And so that basically says that, there's 2.4 times as many people with hypertension in prison that are getting medication. And you see something similar for all these other chronic diseases. And this does suggest that even though there may be certain populations whose treatment is better managed while they're incarcerated, it's probably not the case for many diseases. And I spoke a moment ago about how many people don't get substance use disorder treatment while they're incarcerated. And one big reason for that is that the treatments simply aren't available in a lot of correctional facilities. And that's especially true for medications for opioid use disorder. And for those who aren't familiar, there's 3 major types of medication that are used for opioid use disorder. And this is the first-line treatment for that disorder. It's the best available treatment we have. And anyone who's in the community would have access to these medications, but it's not the case for incarcerated people. So this map, which is also a little bit on the older side, but it hasn't actually changed all that much, you can see that many states don't offer any of these 3 medications. And then in the dark purple here, or not, the yellow states are those that offer all 3 medications. That's very few states. That is growing, but by and large, people who are incarcerated don't have access to this first-line treatment for opioid use disorder. Another major challenge, and it's very much related to some of these issues we see in the criminal justice system about undertreatment, is that there's very little oversight of healthcare in carceral settings. So there is one organization called the National Commission on Correctional Healthcare that can accredit and oversee correctional facilities' health programs, but they're voluntary. States don't have to participate, county jails don't have to participate, and so I believe only 17 state prison systems actually have this accreditation, and it's not publicly reported. So the NCCHC doesn't make that information available on their website. On top of that, there's no public reporting of quality measures. So, there's dozens, maybe more quality measures that are reported by large hospital and healthcare systems and payers, so that we can just have some general idea of the quality of care provided by those facilities and payers, but there's nothing like that in the correctional system. It's very hard to see and to find any publicly reported measures of quality. And so that, of course, means that it's very easy for the care to be substandard. There's also limited competition. So in any given geographic area, whether it's a state or a county, there may only be a handful of organizations that can provide, that are equipped or have the capacity to provide care in prisons. And so that just means that there's really not much competition, and providers can get away with more than they might in a more saturated market. And so because of that, lawsuits have turned out to be one of the most important ways that people have gotten their healthcare needs met. And this is true for substance use disorder treatment as well. So going back to the previous slide, a lot of the states that have, since this map was made, the MOUD has become more widely available, but a lot of them, were driven by lawsuits pursued by people who couldn't get their medication while they were incarcerated. We also know that outcomes after prison release are quite poor, health outcomes. So that's especially true for drug-related outcomes. So the mortality rate in the 2 weeks after prison release is estimated to be around 27 times higher for people released from prison compared to the general population. That's a pooled estimate. Some studies show it to be as high as 120 times. So it's very high. And that's also true for other conditions. So it's not just drug-related conditions, but mortality rates are higher for other medical issues as well. Again, partially a result of treatment not being available within prison facilities, as well as some of the challenges when it comes to reentry and getting healthcare needs met. And so, yeah, care disruptions are very common after release. Even in cases where care is provided in corrections and it's high quality, there are typically disruptions when people come home. And a major reason for that is that Medicaid is suspended or terminated while people are incarcerated, so they lose coverage. And then when they leave the correctional facility, if their Medicaid hasn't been reinstated, then they have the lapse in coverage and they're not able to get the care that they were receiving while incarcerated, or that they need now that they're in the community. There's also poor coordination. So there's, within the prison, people typically have a case manager that's helping with reentry, and they may make referrals to the community, but there's typically no one that's sort of guiding them through that process, and it's very much disconnected, just like other aspects of the healthcare and correctional system. And then adding to that, barriers to healthcare are very common in this population. So things like housing and transportation are major issues for people coming home from prison. And so then they're not able to seek healthcare for those reasons. So in that context, there is a lot happening right now in this space, which is potentially going to make a big difference. So there's been, especially with respect to Medicaid policy, there's been some changes lately that have tried to increase access for people after prison release and ensure that people's Medicaid can be quickly reinstated and so they can get the care they need when they return to the community. And so one of these, which came through the Consolidated Appropriations Act of 2024, newly requires states to suspend Medicaid rather than terminate it, starting in 2026. This is also kind of an older figure, but this was from 2019, and there were a handful of states that terminated Medicaid when people became incarcerated, which meant that they would have to reapply when it's time to leave. And that can be very difficult to do from prison. And there's even challenges with suspending Medicaid. So it's not always reinstated quickly when people return to the community. And so in addition to this mandate to suspend rather than terminate Medicaid, this law also provides some funding to support states in better managing that transition and getting people re-enrolled in Medicaid when they come home. I wanted to briefly touch on the Medicaid Reentry Act. So this hasn't actually been passed yet, but it's been floating around for a while now. And this would essentially waive that Medicaid inmate exclusion policy in the 30 days before release so that Medicaid could be reinstated before someone comes home. And then, they would be leaving with coverage. It wouldn't be a question of whether they're enrolled. And they would also be able to get some of the Medicaid reimbursed services towards the end of their incarceration. Another thing that made it into the latest version of this Act 2, which I think is really interesting, is that it's requiring Congress to, or it's requiring a report to Congress on prison healthcare quality and services. So that relates back to my earlier point about the lack of oversight. So there's actually some attention to this issue right now, which I think is really important for moving this forward. There's been another major change, which is that CMS has issued guidance to states on developing what are called 1115 reentry waivers. And 1115 waivers are basically ways for states to experiment or innovate in their Medicaid programs. So they can test out different eligibility criteria, services, or modify other aspects of their Medicaid programs under a waiver. But these waivers are specifically designed to support reentry and improve care transitions for incarcerated Medicaid enrollees. And so you can see here that there's 11 states who have had them approved, including Illinois. California and Washington were the first and are actually just getting ready to implement these now. And then another 14 states are pending. And the main thing that these waivers will do is it'll waive that Medicaid inmate exclusion policy in the 30 to 90 days before release. So again, making sure that people have Medicaid, active Medicaid, by the time they leave the prison, but also certain services will be able to be reimbursed by Medicaid during that final time that they're incarcerated. It does require certain minimum benefits. So they're listed at the bottom there. Any state that gets one of these Medicaid waivers has to cover case management to support reentry. They also have to cover all the medications for addiction treatment, including the ones that I described earlier, and they have to provide a 30-day supply of medication at release. Okay, and so that's going to bring me now to talk a little bit about my work as it relates to all of this. And so I'm going to be talking about a study. It's called the Association of Pre-Release MOUD and Peer Navigation with Post-Release Medicaid Enrollment and Treatment Engagement. And it relates to what we just talked about because it's basically the services I'm going to be talking about are New Jersey's efforts to better coordinate care from prison to the community and support people with substance use disorders as they transition to the community. And the services that New Jersey is delivering right now for people coming home from prison would be reimbursable under these 1115 waivers. So the model that I'm going to talk about is something that some states might consider implementing as they roll out their waivers or develop new services. So just to say a little bit about what's available in New Jersey. So the services within the prison system are pretty robust for substance use disorders. Among other services, they provide medications for opioid use disorder statewide. So going back to that map earlier, New Jersey was one of the states since 2017 or so that offered all three forms of MOUD to anyone who is incarcerated, at least in the 6 months before release, and in some cases longer too. They also implemented this statewide peer navigator program, which I'll talk about in a moment. And they provide Medicaid enrollment assistance actually by law. So there was a law passed in 2020 for COVID and then made permanent in 2021 that requires the Department of Corrections to enroll people in Medicaid before they're released, if eligible. And yeah, so this sort of traces the history of MOUD in the prison system, but really it's been widely available since about 2017. And about 4,500 people have been prescribed MOUD since that time. But it also has this very innovative peer navigator program. And so for those who aren't aware, peer navigators are people who have lived experience in common with those that they serve. And they draw on that lived experience is really where their expertise and their ability to help comes from. So, unlike a social worker who may or may not have lived experience, but is trained in different modalities of helping people, their expertise really derives from their experience with those things that they have in common with the people they serve. And so in this case, it's people who've been incarcerated or have a substance use disorder or both. And some of the benefits from the literature of peer services is that they can, in some cases, have an easier time building rapport because they're able to establish trust with people who share their lived experiences. Unlike, in some cases, a social worker, and especially with the incarcerated population, they haven't always had good experiences with the healthcare system or with social workers or the government more broadly. Peers can also provide a source of hope and act as role models since they have actually walked through this process that they're trying to guide people with. And they typically have a very good understanding of the resources in the community. So they know what's out there and they know what to connect people to, both formally and informally. They can help connect people to other types of social support resources that social workers or health providers might not even know about. And so the way this program is operationalized in New Jersey is that each person who has a substance use disorder and opts to participate in this program is paired up with a peer navigator about 6 months before their release. And that peer navigator goes, throughout the state and goes into the prison, meets with the person several times in person before release, and develops sort of a plan, a relationship, and then they continue to work with them for up to a year in the community. And it's very much like a patient-centered approach. So they don't really, it's voluntary. They don't impose any particular treatment or recovery pathway on people. It's basically like, we're here for you for anything that you need as you navigate this very difficult process. And for some people, that means like, give me Narcan when I come home so that I don't overdose, and I'll call you if I need anything else, or I need a ride to my parole appointment. And for other people, it's very hands-on assistance with getting to medical appointments. And I think that's one of the really interesting features of it, is that it's not a very, it's not prescribed in detail. It very much follows the client's needs and wishes. And it also has this long continuity, so 6 months before release and 12 months in the community. One of the things that CMS is encouraging through the 1115 waivers is in-reach programs. So the providers who provide the services in the prison, they want them to be also community providers so that they can establish a relationship with people they serve in the prison. And that's how this model works. In addition to the peers in this model, there's also a team of case managers, nurses, physicians, and others who help with some of those other needs that people have that the peer navigator isn't necessarily trained to address. And so some of the services provided in that peer program is peer support, reentry planning, linkage to treatment, transportation. This last one, smartphone at release, has turned out to be very helpful from qualitative data. So many people don't have a phone when they come home, and they don't know how to use it because they've been incarcerated for many years. And so the program will actually give them a phone and help them use it. And that's also been very important for how a lot of services are delivered now virtually. And so the aim of this research was to look at the association of these two interventions, peer navigation and medications for opioid use disorder, with Medicaid enrollment and post-release treatment engagement among released people with opioid use disorder. And so I'm focused on opioid use disorder in this case, but these services are also available for people with other substance use disorders. And so this study uses a linked data set that I've been working with some people in New Jersey to build over the past couple of years. And it starts with the administrative data files from the New Jersey Department of Corrections, which has anything related to their incarceration, what they're incarcerated for, the services that they got while in prison, demographics and other personal characteristics. And then it also has all the healthcare records from within the prison. So we can see the diagnoses, counseling, medications, pretty much any kind of health services that were used while incarcerated. And then we link that to all these other external data sets in New Jersey, which including Medicaid claims, hospitalization records, death records, and then with potential expansions, we're also working on integrating emergency medical services data and homeless management information systems data. But for this particular analysis, we only used these two data sets, which were the administrative data files from the DOC and Medicaid records. And just to give you a sense of what's included in those, so the DOC records are in the first two columns, and I just described those, but it's things like demographics and anything related to the incarceration and reason for incarceration. The medical records, again, contain diagnoses and services received while incarcerated and some results of behavioral health screening instruments. And then the Medicaid records help us see the services, the healthcare services that were received in the community after release. And so there's two samples. So the first sample is broader, and this is the sample that we used to look at the association of these interventions with Medicaid enrollment. So basically trying to answer the question of whether peer navigation and receipt of MOUD before release are associated with greater Medicaid enrollment after release. And then we created a subsample from that sample with slightly more restrictive criteria that we used to look at service use in the community after prison release. And the outcomes we were interested in were Medicaid enrollment. So, whether people had Medicaid active by the time they got into the community. And then we looked at receipt of substance use disorder treatment services after release. So medications for opioid use disorder, any of the three medications within 30 or 180 days. And then we also created a measure of, it's sort of like the length of treatment, which is represented by the proportion of days covered with medication in the 180 days after release. And then we also looked at psychosocial treatment, which is basically like counseling or therapy or anything that doesn't involve medication. And we looked at any receipt of those services and ongoing engagement in that type of care. And so the exposure in this analysis was receipt of the services. So whether people received peer navigation, MOUD, both or neither service. And then we adjusted for essentially everything that we could that might be related to these outcomes. Things like demographics, criminal history, other diagnoses that it might impact Medicaid enrollment or service use. And we used inverse probability of treatment weighting to account for the differences between the group. And without like going too much in the weeds about what that does, it basically balances the four groups, the four treatment groups on other observed characteristics. So it basically makes them a little bit more equal so that you can compare them, make a more accurate comparison in outcomes between the four groups. And then from those models, we generated adjusted outcome probabilities by treatment group. So we essentially looked at what's the probability of being on Medicaid and what's the probability of getting treatment in the community depending on what services you got before you left the prison. And so here's the demographics of our sample. So it's a younger sample, 47% were 18 to 34, mostly white at 46%, and mostly male, 90%. And here's the breakdown of who got what services. So this is, again, this is everyone who had opioid use disorder who was released in these 3 years, about 7,000 people. And 60% of them didn't get either of the services. The next largest group got only medication, and that was 23%. Another 11% got both medication and peer navigation, and about 6% got peer navigation only. And so here's the adjusted probability of Medicaid enrollment after release. And what we see is that the people who received both medication and peer navigation, that's this bar right here, were the ones who were most likely to be enrolled after release. So that's about 91% of people, which is quite high. It's hard to say what proportion that represents of people who would be eligible for Medicaid, but there are, of course, some people leaving prison who don't meet eligibility criteria. So it's approaching most of the people who you would expect to be enrolled in Medicaid. And that also compares to 76% who didn't receive either intervention. And this is also with I mentioned earlier that the prison system helps people enroll in Medicaid. But this does show that if people are getting these other services, that does seem to help increase the likelihood that they will be in Medicaid after release. Because even if the prison system helps people apply, there's often disruptions when they come home where the application may not have been processed in time for them to leave prison. And so that's where the peer navigator could potentially be helpful in resolving some of those issues. We see a similar pattern when looking at post-release receipt of medications for opioid use disorder. So the people who received peer navigation and medications were the most likely to have received any. So the lighter bars there are any medication within 30 days of release, and the lighter bars are any medication within 180 days of release. So 60% of people who received both interventions had received any medication within 30 days, compared to just 4% who hadn't received either intervention. We also saw that the people who received both of these interventions had a higher average percentage of days with MOUD in the follow-up period. So this is basically a measure of like what percentage of the 180 days after release did you have medication supply. So 45% in that case would, for those who received both IRTS, the Peer Navigator program, and MOUD, they averaged about 90 out of 180 days with medication. And that compares to smaller numbers in the other groups. Yeah, of course.
Is there like a gold standard, like would 100% be the ideal, just so we can
Yeah, no, thanks for asking that. That's a good question. And I think it relates to this slide too, because 60% receiving MOUD in 30 days is high, and 76, 180 days is very high. I don't have really a good answer for that. I don't think it's necessarily 100% because there are a lot of patients who don't want to get on medication for various reasons, or in some rare cases they can't because there's an interaction perhaps with the medication or some other medical reason. And it's really important to respect people's wishes for their own care. So I don't think it would be 100, but yeah, I'm hesitant to put a number on it. I think 60% is a good number. Yeah. I'm curious if others have thoughts on that. That's a good thing to talk about. So yeah, we see a similar pattern when it comes to psychosocial treatment. So that, again, things like counseling and therapy, where the people who had received both of these pre-release interventions were more likely to be receiving those services after release. And here, again, engagement. So engagement in psychosocial treatment, basically we defined it as receiving 2 or more of these services after the first service. And people who had received peer navigation and MOUD also were more likely to be engaged in those services longer term